General for Alpha Phi Alpha Fraternity Incorporated. On behalf of our General President, Brother Lucian J. Metellus, and our Board of Directors and the Deputy Surgeon General, welcome. Tonight, we are going to have a little bit of fun. We hope you find this incredibly informing because it's pertinent and it's something that involves everything that everyone seems to be doing. And of course, we're talking about Dr. Google. We actually want to arrange this conversation for you so that you know how you should and should not be using Google and AI as an adjunct to how you health. In our last discussion of this type 2 months ago, we actually looked at the future and public health ramifications of AI and other web-based means of obtaining information. But this evening, we have three of our Deputy Surgeons General representing dental health, mental health, and family health who will be talking to you on those very matters. So let me just begin just by introducing our panel for this evening, which, as I mentioned, consists of three of our Deputies Surgeon General. Our first is Brother Ron Kennedy Bailey, who is Alpha's Deputy Surgeon General for Mental Health. Brother Dr. Bailey is the Kathleen and John Bricker Chair, Professor, and Head of the Department of Psychiatry at LSU Health Sciences Center. He's also Chairman of the Board of Trustees of the Cobb Research Institute and the past President of the National Medical Association. He also is the incoming, or I should say, President-elect for the American Black Psychiatrists Association. So welcome, Brother Bailey. Our second panelist is our Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse is a spring 1990 initiative of the Rho Iota chapter of Alpha Phi Alpha, and he's currently active in the Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine and is the Director of Clinical Research in the Division of Hospital Medicine. He is board certified both in internal medicine and geriatric medicine and is a fellow of the American College of Physicians and the Society of Hospital Medicine. Brother Narcisse, I think you've gotten an upgrade, a promotion since then. Am I correct?
I think that's right. I'm now the Division Head of Hospital Medicine, Division Director of Hospital Medicine. So thank you for that.
Outstanding. Congratulations. Yeah, so we never want to shortchange your excellence.
Always trying to keep up with you and Brother Bailey.
And speaking of excellence, we have a man that I love to introduce as having been Alpha Man of the Year in 4 different chapters and the Eastern Region Alpha Man of Merit. Our Deputy Surgeon General for Dental Health is Brother Dr. Langston Smith, who received his DMD degree from the University of Kentucky. He subsequently followed that by joining the U.S. Navy and served 30 years on active duty, having completed a Navy fellowship in endodontics at the Naval Dental Center. Dr. Smith is a diplomat of the American Board of Endodontics, receiving certification in 1992. He also served as associate professor and chair of the endodontics department at Howard University College of Dentistry in Washington, D.C. for 12 years and has a ton of military awards. But again, in the context of this conversation, having been the Alpha Man of the Year in 4 different chapters across Alpha Phi Alpha speaks volumes. And of course, he is worthy of that each and every year, as are all of our panelists this evening. Good evening, my brothers.
Good evening.
So what I actually would like to do at the beginning of the conversation is just to, because we have so many things we want to get into, I want to run through an introduction for the audience. I just am going to take liberty here before we get our panelists involved in the conversation and just point out some pretty basic considerations. More or less talking about how to use Google safely for health information. Now, I'm going to give you 5 things that you should use for and 5 things that you shouldn't use for. So if you're keeping score at home, kind of think through this. And I know that people use for more than what I'm going to describe, but just kind of think about it. Google actually is pretty good for basic orientation. If you want to know what a condition is, if you want to know what common symptoms of a particular disease are, if you want to know what type of test or treatment you would get once you get a diagnosis, that type of basic orientation is something that Google is very good at telling you. It's good for picking out reliable information. One of the first things that I would try to tell you is consider the source. Look for reputable sources that are from academic medical centers or professional medical societies, things that you know and trust, like the Mayo Clinic. Historically, we would have added CDC and NIH. Those are the type of things that have checks and balances, are globally renowned and recognized. Consider reliable, trustworthy sources, and you will use your own barometer to determine what you trust. Google is also pretty good for getting ready. It helps you know key terms so that when you go speak with your physician, you don't hear medical jargon and not have a clue about what you're hearing. It's very good at helping you to gather questions and understanding to what to expect. So in other words, Google is great for helping you get ready prior to a physician evaluation. It's also very good for medication basics. If you want to do some research on drugs, you can get some medication guides, also pharmacy resources, hospital resources. These things can be very informative, educational, and applicable depending on how you use it. And finally, the fifth thing that I would point you to using Google for really would be to help you locate care. It's very good if you put in your address or zip code. It can help you find the closest urgent care specialists, clinic hours, and even reviews of those facilities. So that's basic orientation, reliable information, help getting ready for an evaluation, medication basics, and locating care. Now I want to pivot very quickly into 5 things that you shouldn't be using Google for. And at the top of that list is diagnosing. I can't tell you how many times people come to me and says, I put this, that, and the other in Google search and it told me I had this disease. The problem that you all have is that you think linearly. And medicine is akin to three-dimensional chess. And symptoms are not linear A plus B equals C. There's a lot more involved in it. Symptoms overlap and search results can mislead. So please don't ever try to do that. But getting information to prepare you how to ask questions, you're on point there. Similarly, trying to interpret labs is folly. Summaries can be inaccurate or falsely reassuring. One abnormal test out of 15, which you may focus on, may not be important at all. Lab errors do occur. You don't have the benefit of knowing how to interpret them or knowing when to have those repeated. Don't even try it. Take those questions to your provider, your physician, and go that direction. Also, don't use Google for urgent decisions. If you're having something like chest pain, trouble breathing, any neurologic changes, trust me as an emergency physician, time is tissue in many of these instances. That requires real-time medical evaluation. You should be calling 911, not flipping through the pages of Google. And finally, do not use Google for AI-generated health guidance. AI overviews have been proven unsafe and to provide incorrect advice in many instances. Focus on what it is you should be using it for or could use it for, but remember this, use Google to get oriented and use clinicians to get answers. We are not at a point where you can be Dr. Google and replace healthcare or medical care. So let me begin the conversation with our panelists. Let's bring everybody on board and see if anybody wants to add anything to what I said or rebuke or rebut any of what I said before we move on to the other part of the conversation.
Yes, I'd like to start.
I'll jump in next. Go ahead.
It's a frequent thing when patients come to me and said, I've got such and such problem because I did a literature search in my browser and it returned XYZ problems. Don't you think I should look for X or and again, the issue that I have is not so much that it hurts my feelings or it makes me feel that my years of training and decades of experience are diminished. It's actually a harmful use of their time because I have only a finite amount of time with the patient and their family. And if I'm using that time to unwind the conclusions that they've come to, it actually limits my ability to actually listen to what's actually going on with the patient, develop a strategy of evaluation and testing and treatment. So it actually, I actually find it harmful. And again, many of the patients and the families who come and said, I'm worried about X. I said, well, maybe that's not an unreasonable thing to think about. But as I teach my medical students on a daily basis, just because A can be related to B means that A is equal to B. So I think that it's very simplistic to interpret. I read this thing and it covered one item that could be one of 100 things that could be going on, and the search browser said focus on this one. So I worry about that a lot, And I find it very much detracts from the patient's experience, because then when I tell them, well, that's not the issue that's most concerning to me with my training and my experience, then they feel very, very disappointed that that's not the answer that's going on. And it usually, whenever the conversation starts with I did this Google search, it frequently leads to someone being disappointed with what happens next.
That's a fascinating construct because it posits as to whether patients are coming as consumers or as clients, looking for partnership to maintain their overall health. And I certainly think back to the commercials that said, ask your doctor about this. So I want to just reaffirm what you said there, because people don't appreciate when they get to see you, if it's been 6 months or a year since they've last seen you, how difficult it is to compress everything that they actually need into a certain amount of time frame. So would you recommend one way or the other the point in time in which patients ask questions or express their concerns during their visit with you?
Actually, I think it can be quite helpful. Again, I see patients mostly in the hospital, so I see them every day for a shorter period of time, and it's usually a very, very high intensity consideration. But I think it actually, after that we've had this conversation of, here's what I'm concerned about. Here are the symptoms that I'm having. Here are the problems that I'm having. What are your thoughts? I think that it's fair and reasonable for the patients to say, hey, I did some reading, I did some research. After I've sort of given them a basic overlay, how does this fit with what I've read? I read X, you said Y. Can you help me understand? Can you educate me on the difference? And
Okay.
so what I do find, though, is the more common experience is, well, my Google search is correct and your alternative answer is problematic. And so then there's a distrust. And so what I usually tell folks, if you want Google to be your doctor, go right ahead. You can follow, ask them to write the prescription, but I'm the one in my state who's authorized to write a prescription. And so my version of the answers is something that we should at least discuss.
Very
I have
good.
some thoughts,
Brother,
Jeff.
go for it.
Yeah, I first of all, 100% agree with actually both your earlier comments, which are right on time, and particularly Victor's comments. This idea that the doctor remains the physician responsible for your care. I agree with Victor 100%. I'd also add that in psychiatry, we're particularly uniquely situated to struggle in this business, because the reality is AI and what have you, as I understand, is really geared to focus on positively increasing efficiency. By definition, psychiatry and psychology is inherently an inefficient process. If I get 6 visits to see you, because that is what makes most people, but if you need 8 or 9 or 17, I'm trained, as Victor just said, to give you 17 if that's what you need to address your problem. And psychiatrists all over the place in regards to the level, I think, of intensity of the degree of problems that other people have, because we aren't able to diagnose with laboratory. No blood test or urine test gives the exact answer. It, by definition, is a clinical orientation and a clinical field. I'd also say, though, that there were pros and cons in all aspects of what we do. And there's some pros in the use of AI, as well as pros and cons in the use of a physician for care. But the reality is, one huge issue that machines will never be able to replace is the issue of remorse. The reality is humans and assets like machines and algorithms lack remorse by definition. And at times, the best choice, strictly based on the data, would be something that's adverse for you. I may give you more time, a second chance, a better attempt, I think, to reconfigure your program and stop engaging in the behaviors that put you in a bad way and do better. The data may argue that people do that in 3 months or 6 months. It may take you 9 months or 2 years. But as your doctor, I'm your advocate, and I'm there to make the best decision for you over time, if that requires more from you than it might take in other type settings. The lack of remorse, I would argue, could also lead to adverse outcomes, particularly in psychiatric medicine. ChatGPT, Google Gemini, all I think provide, I think, a very dispassionate and distant, although beneficial tool, but not one in which remorse, which is remarkably and intangible can be measured or given freely to a patient in need. I also said that when you do want to discuss, I love your point, Jeff, how can we use AI? That's what we should be talking to patients about in our society and our community. Because very often, as their doctor, as Victor said, we should be their trusted messenger, the one who would actually believe in. They should decide that they believe in the machine or the data or what Google Gemini says versus what we would say. So the reality is they should learn about their symptoms, have access to the right resources, know how to find and provide care from service providers. A lot of value can occur by using these tools, but very different than replacing the doctor, especially the psychiatric doctor, I think, in that type setting.
Wow, you two are coming in hot tonight. This is good. I'm going to let you guys flip the
I would
script
make
and talk
one
about.
one other comment that would
Don't
dovetail on what
keep it
Dr.
going. Keep
Bailey
it going.
said.
Let's go.
That one of the things we say at work all the time is the computer will never hold your grandmother's hand once she's dying. So I would actually, Dr. Bailey said remorse. The way that I think about it in my adult practice, I think of it as empathy. That's the piece of humanity that the machine learning and algorithm can never emulate. And so I think that's a key part of what we do, is that we provide this human interaction. It's not just that we give you a diagnosis. Someone could mail you a letter that says, here's what's wrong with you. But the ability to have a discussion, a bi-directional discussion, and one that listens and understands the things that are most important to you, and tries to craft a patient-centered plan around that, is actually quite helpful.
That's where I want to say it.
I'd agree.
And that's where I want to say it. Brother Smith is having some technical difficulties, and we'll work him back in. Because my experience in an emergency department, surprisingly, given that I have much less time than you gentlemen do in your respective fields, the first thing that I'll tend to do when someone comes with me with information that doesn't add up is I'll just completely divert them to a different conversation, which the conversation kind of goes like this. I congratulate them for actually being assertive and showing initiative and caring enough about their health to try to be empowered. And I'll take the information that they gave me and try to very quickly tell them how to investigate the concerns that they have, how to bring those questions to us, and how to have reasonable concerns without having unfounded fears or irrational fears. So we're in the next part of the conversation. We actually are going to do a deeper dive into each of your specialties, but I really want you guys to focus on the ways in which we can empower the audience members and members of the general population to appropriately use Google and AI for what it is worth. Brother Smith, Dr. Smith, you're back. Are you able to chime in?
I'm here.
All right.
But
I guess you
I'm
can't hear
having
me.
a very difficult
All
time
right. If
following.
you have points that you want to make, go ahead and put them in the chat, and I'll certainly communicate them.
Wow.
But let's go back, Brother Narcisse. Let's go to you, because you actually started on this, and I wanted you to actually continue this. If there are people, as there are family members, given that you're a hospitalist, a specialist, and a physician that deals with geriatrics all the time, you're dealing with a lot of family members who come in to see you as well. And when people are admitted to the hospital, they always have questions. They always have concerns. They always have fears. And they're getting that information from second opinion locations, usually that people that aren't medical. They may have a family member who works as a medical technician or phlebotomist, and more often than not, they're on Google, or they're these days using ChatGPT or some AI to do that. Can you just take a minute and give some advice to people as to how to organize their thoughts in ways that are helpful to assimilate the information that you're trying to give them and things that they should be concerned about?
So this is very important. Hospitals and doctors long have been given essentially a grade of patient experience. And what has happened in this past year is that the surveys used to be exclusive to the patient and now are extended out to the family. So the conversations that we have are not just focused around the individual patient, but also their trusted advisors, spouses, parents, children or friends. So we definitely have to include them. So what you're starting to see is an attempt to extend the conversations to those individuals. So now we're actually encouraged to try to call family members every time we're in the room. When my mother was hospitalized and was ill in another state, I had a very difficult time to get information. So one of the key things is that we're trying to use technology to bridge this. So whether it's a video chat or just an audio one, this is a key piece. And so what we ask children to do, or family members to do, is to write down your questions. Again, when I come by, my time is quite limited. If I can connect with a patient or a family member, their time is likely to be limited as well. So if they have written down the questions that they like to review in advance, then that's a helpful thing. Not necessarily put them all through an AI filter, but actually just write down these things. So I think that part of the communication is actually quite important. And I think that it's not your question, but I'd like to just bring up 2 quick points of how AI is changing what I do. As I think that it's clear that AI is going to augment what a lot of physicians are working on. And so in my hospital, there are a large number of AI pilots. From radiology, can we look at chest CTs to find a blood clot? We're using AI to try to summarize the chart into a condensed section, so that when I discharge the patient, the discharge summary can be at least started by an AI piece. So there are a number of areas where AI can actually help physicians provide the care. And I think that you'll see much, much more of this. But also, as other industries are looking for AI solutions, I think you're going to see that the insurance industry, they actually do a review of cases. Should I pay for this imaging test? Should I pay for your surgery? Should I pay for you to go to a post-discharge facility for rehabilitation? A lot of that initial work we're seeing is actually being done by AI. And so the decisions that we're accustomed to having been done by live people now are increasingly done in an automated fashion. So I think that we're going to have to, as a society, really pay a lot of attention to how AI is inculcated into the activities that we see. Is this a decision that you made, Dr. Narcisse, or did somebody make this for you? Did someone help you with this? So I think that those are going to be over the horizon kinds of questions that we're going to be dealing with in the future. What I'd like to see family members do, again, is to develop questions. I think when family and friends do some reading and have a basic understanding of the issues at hand, I think that's really value added. And so I really loved your comments, Brother Sterling, about using technology for the preparation.
Yeah. Brother Smith, I'm trying to see if I can get him into the conversation. He looks like he's still frozen, so we'll just keep it there. You actually you were picking up what I was putting down. My next conversation point really was going to be about 2 different ways in which we see the future diverging. One is the ways in which clinicians will use AI to augment care, and the other was with how we can continue to empower patients to use AI after their interactions with us. Hey there, Brother Bailey, I see you're back.
And I'd love to jump in. I hate to cut you off. You're right, a lot to say tonight, but he's always go fast. But as typical, Dr. Norris, he's on top of his game, and he used the term conversation. And that was really the second point I wanted to make tonight. I think in many regards, hospital practice and psychiatry have a lot more in common than we recognize. But the reality is, we're trained in psychiatry. I want our audience to know to have a directed conversation. Some people say you're just talking to people. I would kind of disagree with that. It takes training to have it directed. They say a lot. I may say very little. They say very little, then it may need me to say a whole lot. They certainly need to say the right thing at the right time for them. And that's why it often takes more than one session to learn what their real needs are. AI can be remarkably beneficial in helping an individual prep as I think Dr. Narcisse said very articulately, for a better, more effective, more bi-directionally beneficial session. So I strongly encourage it. It's actually very beneficial. But again, as both my colleagues I think have said tonight, it shouldn't replace the doctor. It should help the doctor do a better job for you by enhancing your knowledge base for what some of the key symptoms, for example, can be. You don't use have to say that these are the issues that I think I have because I read it in a book. But you might argue that I appreciate for what I've received from AI, from what I've read, that these are some of the kinds of considerations that I should bring to you as a doctor to help me with. The second thing that I'd say, Jeff, as well, that's so important, is that when that conversation occurs, the individual patient can then leave and go back to their home, their office, what the case may be, and read about what the discussion has occurred. That, to me, makes the second visit, which I think very often is a very important visit in my long-term therapeutic alliance development with you, much more beneficial. Because then I think they don't come back for the second or third visit unaware, and they've forgotten some of the gains that have already been made, the key points that have been shared. That's why it's my job to start off with it and kind of finish with it. You tell them what you told them, and tell them what you've actually said again, to kind of get them on the right track. That begins to develop, I think, the joint relationship needed over time with the gains we need in developing a therapeutic alliance, A, developing the trust that's needed between doctor and patient, B, and then at some point getting them to buy into your therapy or therapeutic conclusions or recommendations so that they will take them. My final point is a huge issue for us all too often is that if a patient is much more technically savvy and they want to read it at some point, it can very often support and provide a positive second opinion, so to speak, of what the doctor has said to them. That, for me, all too often can enhance medication compliance because the patient really believes that what I'm saying is correct. They went and read it in another source that they also believe is just trustworthy. So the three key tangible variables that they can all be elements of the use of AI that can be helpful in psychiatry.
I have a
I'm
question,
going
Bailey.
go ahead.
My question about individual patients putting their essentially medical history into a chat engine, what concerns do you have around privacy? As a physician, we're actually prohibited at my workspace of using a public AI engine, although there have been some AI engines built into our electronic medical record. But the kind of AI engines that are available to a patient, if they go into their browser from their computer and they say, I'm worried about, here are the risk factors for suicide. Does that have any insurance ramifications for them? Does that create a digital profile for them? If the next time something happens in town, or are there any concerns that your community has developed around this?
Substantial. I think that we start off by saying, I think both you and I, maybe I think Dr. Smith as well, that there are both pros and cons to all of this. The pro is the extra information, the development, I think, of the additional confidence in
We lost you,
recommendations.
Brother Bailey.
I'm sorry?
Oh, he's here. I hear him.
Yeah, and additional trust
Okay,
that we
keep
spoke
going.
of earlier. But I think Dr. Smith is 100% right. There clearly are cons, we mentioned earlier. You described a technology a few moments ago that all persons may not be aware of, that when you put something into the engine, it may keep it and use it in other settings going forward. By definition, that can be adverse. But the same token is problematic if you go to somebody's office and they don't have a confidential admin or staff that at some point let information kind of leak out. So these are some of the cons that can occur in that same setting of the misuse of information that's shared with you professionally. I think even when you do it in a humanistic perspective. So you're 100% right. There certainly are concerns to be mindful of. I wouldn't recommend it or expect it on a wide scale basis. But tonight's a great conversation because we are discussing, I think, parenthetically, that there are certain pros and cons that can come from the use of AI. And that's part of why, since patients are using it, many of them, mine as well as yours, Dr. Smith's, we probably should be more conversant about the pros and cons with our patients. But I think you're 100% right. It can be used negatively when in the wrong hands and under the wrong circumstances and interpreted wrongly as well. So patients should be aware.
All right. Are you able to hear me? So I'm going to challenge you
I hear you well.
guys because what I want to do is I don't want this to get so academic that it loses the audience. I actually want to challenge you based on what the people believe. The people believe that these AI tools are, in fact, either a high-grade supplement or a replacement of some sort. In the same vein that physicians have physician's assistants and nurse practitioners and other people, is there a way that AI or Google can slide itself into, more AI than Google, obviously, can slide itself into some use for some low-grade considerations? I mean, hell, we even have telemedicine and telehealth now. Once again, if you looked at it from psychiatry, you have clinical psychologists. There's many levels of professional that provide different levels of care. I'm coming to you first, Brother Narcisse, and then Brother Bailey. Do you see, because I think that consumers may force this part of the conversation, what role would you see this being able to take over instead of just supplement and augment the services of physicians and other healthcare practitioners?
So I'm a member of the American College of Physicians, which is the largest organization of internal medicine, adult internal medicine physicians around the country. And the position of our organization has been very, very clear that we believe that there's a real role for AI technology to supplement the decision-making logic that physicians do, but it's hazardous now and in the future if there's an attempt to actually replace. I think that the nuances that we learn in our training of not just what was said but how it was said is something that that's not necessarily picked up by a keyboard typing into a device. So I think that that's really clear. I think that it's very important for there to be a lot of transparency on how AI is being used, how it's being developed, what the information, where the information is stored, where it can be used or misused. And I think that the privacy and the confidentiality is something that is not necessarily appreciated. In other industries, there've been episodes where in imaging and in digital and in video where libraries of work were used to train AI devices, and then the information was used in a way that was different than the original consumer intended. The same risk is available in AI in medicine. And so I think that the privacy piece is going to be really, really big. So I think that if you're going to use AI in medicine, if AI tool is going to be used in medicine, then they have to go through a rigorous amount of medical clinical evaluation on the backside, the way that we develop medication. So just because Dr. Pepper or Coca-Cola can be developed as sweet drinks, we don't currently think of Coca-Cola or Dr. Pepper as interventions that can solve a problem for your high blood pressure or your headache or your tooth pain, although that once these things were advertised as such. So the same kind of rigor has to be applied to search engines, so to AI engines. So if you're going to use AI to try to augment decision making, then the AI piece has to be assured that it works. And right now, it's really the wild, wild west. It's just the only check or balance to the quality of AI is the fact that this consumer continues to use this AI device.
Let me give you an example, because this is a pretty important point. Emergency medicine is very amenable to the question that I asked. There are models, famously, it's an emergency department, it's not a room. A department has divisions. Sometimes in some facilities, there's like an ED7 where there are 7 divisions, a resuscitation room, a main ER, a peds area, a fast track, things like that. It is entirely conceivable, and there are models elsewhere in the world where over the years, over the course of my professional career, where you had a physician in triage, then you had a nurse practitioner or physician assistant in triage. Now you have nurses in triage. The triage function is only sorting. So it is conceivable to me that you could have a model in which you have some automated function that, based on criteria set up by a medical director or department chair, that a patient would then be directed to a different division of an emergency department for ongoing care. So, getting back to the question that I asked, in that type of analogy, is there any way that you could fathom, other than just preparation and support of your services, where an AI function could actually become a functional part of healthcare operations?
So I think that the easiest way to understand this is actually the paper form that you would fill out when you go to the doctor's office.
Okay.
You're a new
Right.
patient. Historically, you go see the doctor, they give you 5 or 10 or 15 pages of things to write, boxes to check, and then someone would take that information, collate it for the physician, share it with the physician, and the physician would then say, oh, I see you're here for a headache, but you also have nausea and vomiting and fever. Boy, that sounds like something I need to really pay close attention to. So I think that you'll see a future state, and in fact, in some practices, a current state, where the portal that the patient portal, which is HIPAA protected, not in the Chat GPT, Google AI space, but a protected space, you actually can enter information, and it could then take these pieces of information that you've entered and said, boy, it sounds like you need to see not just the primary care doctor, you might need to go to, somebody may need to think about taking you to the emergency room or something along these lines. So I think that you're going to see more and more of this type of triage. As I don't know any practices in my community that actually still use paper intake forms. All the large practices in my community really use a computerized portal, and so the information when you first come into the office is all put there. So I think you'll see a lot of not free AI workspaces, but actually collated workspaces. So again, the difference is that the AI engine would be inside the practice, inside the HIPAA protected firewalls, rather than
Okay.
something that you would do on a free browser.
Yeah, that's fair. What I'm sensing here, and I'm not disagreeing with anything you're saying. I'm actually just looking at the other side of the coin. I am completely knowing, and I've spoken about this, about what the migration of healthcare clinical operations has been in emergency medicine. I actually can see a future in which AI is heavily involved in the triage process, where AI works as some type of, we have scribes now, but some type of clinical assistance that says, based on this chief complaint, here's what I would recommend. Even before, because we move the room, we may actually order tests in advance of seeing patients just to keep things going and to make things more efficient. I can see, based on a chief complaint, where an AI generated module may actually recommend a battery of tests for the physician's approval. And then based on the integration of the labs, the x-ray studies, and things that have been inputted into an electronic medical record, where something is generated through an AI prism to create a differential diagnosis and ask you, are you satisfied with your evaluation along those lines? Are you understanding where I'm getting at?
Oh, yeah,
Is that, yeah. So do you think that there's any applicability where in hospital medicine? Because I can see it clearly in emergency medicine.
I do. And again, I was pulling out my phone because one of the apps that we use that I'm piloting in my hospital is a technology that's called passive listening. I don't know if you guys are using that now. So if I use this pilot with a patient, I push a button, my phone then records what's going on, and it actually interprets the information and sorts it into my documentation. And then it could actually make recommendations to me. Hey, by the way, this person had fever and nausea and vomiting, and it has a rash and has neck stiffness. Boy, here's some of the things that you might need to think about. So I think that you will see this type of technology supported throughout our industry. I think that there's a zero chance that physicians won't be using AI in a dramatic way in the next 5 to 10 years. But again, the issue that the American College of Physicians is very worried about is the privacy and the
Let's get back to that.
accuracy.
Let's get back to that because you've harped on that many times and appropriately so, and we haven't given it appropriate discussion. What I'd like to do is to actually distinguish between the privacy concerns that occur when a patient is in the walls of a medical clinic or in a hospital emergency department. And you've said it perfectly. In those examples, we are actually required to engage and enforce in certain privacy protocols. But getting back to the very beginning, for patients that are doing the Dr. Google thing and they're at home and they're giving their information to an AI engine, they're not only giving away their data and their demographics to be pitched to later on, but they're giving away their health information, all of which feeds into that. The consumers may not care as much about privacy if they can get some free healthcare via Google or AI on the back end. What should we as a physician community be doing to protect patients from themselves? Because those things can be engineered in some pretty dastardly ways. And I'm not sure the consumers in real time even think of the ramifications of giving away their privacy so willy-nilly when, as you've continued to point out, is such a focus of protection by us on their behalf. Those protections are not in place.
I think all of us have had the experience of doing a search in a browser and then going to YouTube and then getting pushed a whole series of ads, a whole series of information. And so what we often will say is that when you're doing things for free, the price may be very, very expensive. Just like the saying of in Las Vegas, those are the most expensive free drinks in the world. So
right.
Again, when you're doing things and you're not funding the activity, someone else is. And so I think it's really important for everyone to understand that, particularly as insurance payers in the future may look at your browser history and say, wow, this person is looking at cancer, risk factors of cancer, how to take care of family members with cancer. Will that affect someone's ability to be insured in the future? Will that affect someone's insurance rates in the future? Maybe, maybe not. But if I know anything about capitalism, anytime there's an opportunity to obtain an advantage by looking at information, someone's going to do that. So I think that it's really, really important as we use this technology to learn, and physicians do that every day. But I think for the average consumer, they really need to pay close attention to what they're doing. My mother passed away a few months ago, and one of the things that one of my colleagues had pointed out is that they thought that the airline rates, the ticket prices that you're being pushed, is sometimes connected. They thought that they found concerns around connections of the airline rates and searches around funeral homes and obituaries, and they felt, again, unsubstantiated, that were the prices different before they were looking at obituaries and after. Hard to say, but I think that the concern that should be everywhere is, how is the information that you're putting into the public sphere being used? If you search for a very, very private issue, and when I was in training, HIV was the most private of issues. If you're doing searches on that, is someone taking that information and using it in some maladaptive way? So I think it's really important to have these conversations. But it's clear that AI will affect everything in medicine. There's no aspect of medicine that won't be touched.
So I'm going to pause you right there before I kick it to
point.
Brother Bailey. Brother Bailey, you're muted. First of all,
no, he's got it. He's good. I hear him.
He's good. Okay, so let me just say this for the audience before Brother Bailey jumps in. I hope that you have digested what was just said. You run the risk of giving away what has been so dearly protected on your behalf. If you're using search engines and if you're using AI to obtain any type of health information and advice, you must be very, very mindful of the fact that you are giving away health information that physicians could literally be jailed for disclosing. What can happen with your health information by people that are using them on behalf of consumerism is not only expensive, potentially expensive, it also can be very dangerous and hazardous to your health. So if you're taking very much away from this conversation, let's go back to the beginning. Collection of information and advice and gathering information so you can interact with your provider is the way to go. Using these things to diagnose, interpret lab results, and treat yourself comes with risk beyond just making mistakes and wasting time that will be better spent interacting with your physician. Let me toss it to you, Brother Bailey.
Yeah, basically, well said again. I think by both of you. I think Dr. Narcissa's points regarding not giving away information and as you say, that we go to great extremes as physicians to protect is the point that we, by definition, have to educate, I think, our parents and our communities about, I think, proactively. I would say that we have a particular area, I think, of vulnerability in psychiatry and psychiatric medicine, because the reality is this issue of stigma, which I talk about a lot on this show, raises its head. Very often, the exact reason why psychiatric patients are so much at risk in these settings is that due to stigma, many try to find ways clandestinely to ask these questions. So the exact person who'd be likely at home, as Jeff said, rather than in front of the doctor's office or to check off a box on a pre-screening examination in the doctor's office in the waiting room, the exact person who'd be most likely to want to do it in the confines of their own home, using an AI tool like ChatGPT or what have you, to ask the question they don't want to act publicly, are psychiatric patients because of stigma and fear of embarrassment and humiliation if that's the culture they come from. So it's our responsibility to both try to steer individuals, I said earlier, toward accessing more information, at the same time, simultaneously, not taking it as gospel, but using it within the context of the overall doctor-patient exchange. I think I said earlier, and I'll repeat, one value is if the patient uses it in the fashion of gaining more trust, not less trust, in a psychiatric clinician. I'll use some data. We are the profession in all of medicine that's most likely in psychiatry to have a patient go through the whole effort to get an appointment, come and see you, drive there, get all dressed up, pay for parking, et cetera, pay the copay, wait, and the like, and never, I repeat, Jeff Sterling and Victor Narcisse and Langston Smith, never get the prescription filled the very first time, because the stigma that preceded you going through the whole process continues to exist. And you still have it in the back of your head, there's something wrong with me for having this problem. I'm not right with God. I'll go and say it. That's been a long history, I think, in our community. It's something wrongful. I'm crazy. I'm psychotic, rather than just having an affective illness of mood like depression or anxiety. All issues that I spent my whole career trying to dispel and share effective information with individuals and educate them as to the real variables that are in play with psychiatric medicine so that they'll believe in it and trust what we have to offer so it can help them. You talk about long-term outcomes and benefits, preventing suicide, I think as Jeff pointed out earlier, but these issues are recalcitrant in many families and communities to address. So it's our job to be mindful of that, realize it may be a lifetime or career challenge or hurdle as a psychiatrist, but it's important to address because when you can save one individual or life in that setting, you've done a good job. But are patients more likely to expose themselves to that risk? Clearly, because of the fear of and stigma of not wanting to share this information publicly.
I agree. I think it's.
Okay.
I agree with Dr. Brother Bailey that that we need, as a healthcare community, to do a better job of protecting the vulnerable. That's one of the charges that I think that we have, and we collectively have places in our society where that's not done, and that's not done effectively. And so I think it's really important that as we enter this new space, as we go from email to browsers to social media into this next phase of technology with AI, that we understand the questions, the concerns, and the risks. And I think that trying to educate our family members, our community members around this is going to be super, super important. It's
Very
like
good.
It's like
Very good. Very
Doc
good.
Northeast working past the facilities team.
Very
So
good.
what I'd like to the last piece that I'd like to say is that technology is important. If you think that you can be the physician can be the person who holds up their hand in front of the waves and keep everyone from getting wet, I think that that's misplaced. I think that it's important that we as a community understand how this technology is used, how this technology is developed, how to protect ourselves. And this was a fantastic discussion, Brother Sterling. I wish I got to hear more from Brother Smith, but being on with Brother Bailey and Brother Sterling is a tremendous honor for me. And great idea, great conversation, and great insights. I learned a lot.
Thank you as always. Brother Bailey, you have any final comments before I close?
Can't say any better. I think what Dr. Narcisse said is accurate. Excellent conversation. We actually had a big program on this at the National Medical Association back in July. So it's a hot topic. I think that Dr. Narcisse's points are accurate. It's here to stay, and it's up to us as professionals, and I think very often those who care about our community and our society to find ways to ensure that it's used accurately and appropriately and in ways that are helpful and not harmful to our patients.
Yeah. I am actually mindful of the different dynamics that shape healthcare. There's the commercial interest of the payers. Again, we do have a capitalist-driven healthcare system. There's the protective inclinations of the healthcare community, as Brother Narciso so eloquently put it. And there's the silent force, the silent voices of consumers, patients. And when I say consumers, be mindful, we actually do have a system in which healthcare is largely a commodity, in which you are consumers as much as you become patients later on in the process. To that end, it is very much yet to be determined whether or not the ethics that the medical community would impose on AI will win out. It is very much to be determined what the payers, those with the commercial and capitalist interest, will do with this new opportunity to exchange commerce inside of America's largest economic sector. However, we start and we finish with the idea that you, the consumer, you, the patient, have to be the best stewards of your own healthcare. You have to contribute to this conversation. You have to help shape the ways in which this new technology can be permitted to be used, can be permitted to access your information, can be permitted to give you information that can be confusing, misleading, misguiding, and helpful if used correctly. Do not give away your power, your voice in this conversation. Do not become a passive participant in this. I don't think that AI and ongoing expansion of Dr. Google considerations is an if in healthcare. It's not even a when. It has arrived, and the ways in which it moves forward is very much determined between the silent interactions and the silent battles between those three main forces in all of this. We will continue to be here for your questions. This is the second of these conversations. The first was from a public health policy perspective. And the third will be from individuals that are actually in training, receiving their medical and scientific treatment training now, to see what they're being taught, to see what is being forecasted, and to bring that perspective into the conversation to make this entirety of this series well-rounded. We thank you for your questions. We thank you for your viewership. We thank you for your concerns. And once again, on behalf of the Deputy Surgeon General and our General President, Brother Lucian J. Metellus, I want to thank you for participating. We'll see you again next month. Thank you so much for being here, and good night.